Adverse effects of succinylcholine. Is there any problems with succinylcholine?
Yes.
Yeah. What's the biggest one? So so here's the list of the different things, and hyperkalemia is the most ominous. So if I gave succinylcholine, if Chris's potassium was 3.5, and I gave him succinylcholine, it would go up to 4. Okay, big deal. And you can even give succinylcholine to dialysis patients if you know their potassium and it's not significantly elevated. But what if Chris, who comes in with an overdose, has some type of neuromuscular disorder, and I give Chris succinylcholine? What's his potassium going to be? It's going to go from 3.5 to what? 13.5. He's going to code and he's going to die. And I think all of us have had clean kills with succinylcholine, but in our minds we thought, oh, that patient was so acidotic, you know, because what happens? You right as you're just done intubating, the patient goes into cardiac arrest and dies. And I think that a substantial portion of those were clean kills from succinylcholine causing an unexpected jump in the potassium, because we're not able to get this history from the patient. 5 days post burner crush, well, maybe we'd know that. Do we know if they're in rhabdo? No. The old person that's been down on their carpet for 2 days that gets brought in, that's obtunded, subacute spinal injury, we're not going to know about that. Subacute stroke, we'll have no idea if these patients have Guillain-Barré, if they're polio survivors, myasthenia gravis. And any babies, there's no way of knowing if there's inherited myopathy. I would never use succinylcholine on a baby ever for any reason, because that would be a clean kill if they have an undiagnosed myopathy. So succinylcholine can kill patients, and we don't know who those patients are because our patients come in obtunded or unconscious, and we're giving a potentially fatal medication. So that's the second piece of what you're talking about, David, is that, okay, I get it. Studies show they're easier to bag. I get it, I can only use my rescue device if they're paralyzed, but now my alternate actually potentially will kill the patient in that setting. And so, it's good, Deb, that you're not aware of any adverse effects. Yeah, it's good that you're not aware of it, but why would you use something that even has the potential when we really can't validate whether or not the patient is at risk for it? So again, if they have dialysis and for some reason you want to use Sux, it's fine if you know that their potassium is okay. So the next thing is malignant hyperthermia. Has anyone seen that? You have?
Yeah,
cool. Okay. Was it with? Oh wow. So you can't even find case reports of it in the emergency medicine literature, and you've seen it. Yeah, you've seen it. Tom saw a case of it, and I think I had one other student that had seen a case of it, and that's how rare it is. We've been teaching this course for probably 8 years. Now, every hospital is required by law to have a malignant hypothermia cart. So every one of your ORs has this cart, and pharmacists hate it because they cry every year because they have to throw all the medicine away because it expires and replace it. And dantroline's expensive. I can't remember how expensive it is, but it's not cheap. So do you ask your patients if they have a history of personal or family history of malignant hypothermia when you're doing your assessment? No, I don't either. Right, but it's very rare. So trismus, how many of you have seen trismus where you're given Sux, but you go in with the blade and it's just clamped down, it's not working? So yeah, so I'm yelling at the nurse, is the IV infiltrated? Did you give it? What's going on? And so I think most of us just use Bruticane to get past that. But you can, if you do experience that, you can give them rocuronium, which will overcome. It's more common apparently in pediatrics, and I've had it happen to me a few times when I used to use succinylcholine. Bradycardia, is it the succinylcholine or just is it the manipulation of the valleculum that caused the bradycardia? Nobody's really sure, and it's not that big of a deal. And again, when you see bradycardia, the red flag that should go up in your mind is hypoxia. Okay. So I just showed you, I think, 5 slides on the adverse effects of succinylcholine. Now I've got one slide for rock. It has the dosing, the adverse effects, and the reversal. So what's the dose for rocuronium?
1 mg.
Yeah, 1 mg per kg, fireman proof. Okay. So, and what are the adverse effects of rock?
It takes a little longer to tweak it.
It takes 60 seconds instead of 30. True. And so I'm glad you mentioned that. So one practice change is I give the rock first and the etomidate or the ketamine second, whereas with Sux, I did it the other way around, so that way the timing ends up being right. So if you give the rock first and then you push your etomidate or ketamine, then they both basically kick in at the same effect. So the only adverse effect of rocuronium is paralysis. That's it. There's no other side effect. It's not going to cause a fatal electrolyte imbalance. It's not going to cause malignant hypothermia. There's no trismus. There's no side effects, period, other than paralysis. So, and now there's a reversal. This was the old school reversal, but Sugamedics just got approved for the FDA. It's been used in Europe for years now. My pharmacy just got Sugamedics maybe 6 months ago. So now you can reverse the rock if for some reason you need to reverse it once you've got the airway secured. So, go ahead.
When would you do that?
It's a great question. I had to reverse it once. Anyone else had to reverse rock for any reason? So I had this patient came in and she had this dissecting aortic aneurysm from the root all the way down past the renals into her iliacs, and she was in excruciating pain. And so I paralyzed and intubated her, and the CT surgeon came in, and I didn't know this, but apparently the go, no-go decision is whether you even take them to the OR is whether they can move their legs or not. And so I gave rock. So we reversed the rock. She could move her legs. Took her to the OR, she had a great outcome. So that was a case, or maybe for a status exam or for neuro exam for some reason, but that was a teaching point for me. I didn't know that that was their branch point for going. So now it's very easy to reverse rock. Your pharmacy has the Sugamedics, so if you're worried about that long period, you can give a reversal agent and now they're not paralyzed anymore. Maybe 4 years ago, if you took this course, it would have been sucks. Short acting is better because the patient will somehow magically rise back up, and so hopefully you guys will digest that. We took succinylcholine out of our RSI box in terms of meds, so it's not even in there, and we just, nobody, uses it anymore where I work, and they haven't probably for a couple years now. So but it's a big change. Your nurses are familiar with the dosing, they're familiar with drawing it up, so there's a cultural change in terms of your nursing staff, the sequence that you're giving the drugs, those types of things. So it's a change, but it's in the best interest of the patient to have a longer paralytic and one that's safe, that isn't going to potentially cause a life-threatening electrolyte abnormality. Any questions on that? How many of you now exclusively use rock already? So maybe a quarter. Okay. All right. So again, paralysis required when we get in trouble. Placing the tube, so difficult airway cart. This is the cart that I built. It's got these PVC pipes for pediatric and adult bougies, and it's got this tower for the fiber optic.